Thank you for attending, though it looks like we are very few of us. But anyways, so today's our topic is renal and electrolyte disorder. Can you hear me out?
Yes, I can.
Okay. So renal and electrolyte disorder. So let's start with the kidneys first. Okay. So I'm not going into detail. I'm just going to the basic things first. Kidneys. So these are the basically bean structures situated in the renal system. They normally pass they help the body pass the waste as in urine. They filter the blood before sending it back to the heart. When you analyze as the functions of the kidney, so the first function would be filtering the waste materials from the food, medications on the toxic substance, regulating and filtering the minerals from bloods, maintaining overall fluid balance, and it also helps to create the hormones that helps produce the red cells, promote the bone health, and regulate our blood pressure. So types of kidney injury, I'm not going in detail of that because Siddhant has already done that. So types of kidney injuries, AKI and acute kidney insult injury and chronic kidney disease. So what is acute kidney injury? So when there's a rapid deterioration in the kidney function, we call it AKI. It causes roughly around 15 to 20% of the hospital admission. So what are the causes for it? It could be, there are three causes for the AKI. First is pre-renal, renal, and post-renal. When we call pre-renal, it's called when there's a reduction in the perfusion to the kidney. Its causes are mostly hypovolemia. It could be because of any hemorrhage, vomiting, diarrhea, and overdiuresis. Second, it could be because of an apneical. It could be because of renal artery stenosis. It could be because of the drug-induced like NSAIDs, ACE inhibitors, again diuretics. And it could be because of heart failure, cirrhosis, and sepsis. That's a pre-renal. Renal, it occurs when there's a structural or functional damage at the level of the nephrons. And the causes are ATN, is the most common cause of AKI, which occurs because of the toxic injury or ischemic to the cells of the proximal convoluted tubules. Another would be glomerular disease like nephrotic syndrome, nephritic, vasculitis, any intratubular obstructions like multiple myeloma, rhabdomyolysis, and fourth would be malignant hypertension. Post-renal, as it says, post-renal when there's an obstructive pathology. So it's anything that causing obstruction leading to the congestion of the kidneys. That's post-renal, and the causes would be if there's obstruction if there's any nephrolithiasis because at the ureter, any bladder cancer, any prostate cancer, or any BPH, any urethral stricture, and if there's any like retroperitoneal mass or any ovarian mass that compresses causing the post-renal AKI. So that's part my AKI. Now I'm coming to the CKD, chronic kidney disease. So when we say it's CKD, it's like any abnormal kidney function or structure which has been there present for at least more than 3 months. We term that CKD. The most common causes are diabetes, vascular disease, other fluids, glomerular disease, it's the IgA nephropathy, FSGS, membranous nephropathy, any nephrotoxic drugs like aminoglycosides, lithium, prolonged use of PPI, NSAIDs, mesalazine, any obstructive uropathy like neurogenic bladder, BPH, any recurrent urinary tract calculi, and like hereditary sin like polycystic kidney disease or any Alport syndrome. I've just done a brief classification of CKD. As you guys know, it's basically classified by the GFR and the amount of proteinuria. I've just done this on the basis of GFR. So stage 1 would be 90. If the GFR is 90 or higher, it's mild kidney disease. It works well as a normal function. Stage 2 would be if GFR is 60 to around 89. Again, we call it as mild kidney damage, but still it works well. Stage 3 has been divided into part A and part B. Stage 3A would be from if GFR ranges from 45 to 59. We call it mild to moderate kidney damage, but they don't work as they should be. However, stage 3B is around 30 to 44. If the GFR is around 30 to 44, we call it moderate to, it's a stage 3B, and it's moderate to severe damage again. Stage 4 would be if GFR is less than 30, but more than 15, I would say. From 15 to 29, It's a severe kidney damage. They are almost close to the not working at all. And stage 5 would be if GFR is less than 15. It's the most severe kidney damage, means they have stopped working, meaning they're needing dialysis. So that's the only brief introduction of kidneys and injury. So now let's come to the electrolyte disorder. So basically electrolytes, what are they? They are the elements. These are that's naturally found in the body. They are present in the bloods, bodily fluids, urine. They are also ingested with foods, drinks, and any supplements. So electrolyte disorder occurs when the level of these electrolytes in the body, they are either too low or too high. And the body works efficiently when the electrolytes, obviously, they are maintained in the normal range. The common examples of electrolytes, I mean, the common electrolytes are sodium, potassium, calcium, magnesium, phosphate. Yeah. Now, I've just mentioned as a brief symptoms of the electrolyte disorder. I've just gone through the combined one. What could be the electrolyte disorder symptoms? It could be irregular heartbeat, lethargy, fast heart rate, fatigue, convulsions or any seizures, nausea, vomiting, diarrhea, constipation, muscle cramps, abdominal cramps, numbness, and confusion. What are the causes of the electrolyte disorders? So basically, these are most often caused by the loss of body fluids, either through the prolonged vomiting, diarrhea, or prolonged sweating. They may also be related to the fluid loss related to the burns, extensive burns, second degree, third degree burns, and certain medications, they also can cause some electrolyte disorder. So what I've done here is I've gone through the 4 of the main electrolytes out of them, these are the main. Sodium. So as you know, the normal range of the sodium is around 135 to 145. Hypernatremia, obviously, when the level of the sodium is more than 145. Basically, sodium is needed for our body to maintain any fluid balance. It's critical for the normal body functions. It also helps to regulate the nerve functions and muscle contractions. So hypernatremia, what are the causes for the hypernatremia? The first and the most prime important cause would be severe dehydration. Any patients coming with the sodium more than 150 or more than 145, first thing is thinking, is the patient severely dehydrated? Second cause would be poor water consumption. Excessive loss could be as a result of the prolonged vomiting, diarrhea, sweating, medications, some medications like mineralocorticoids. Hyponatremia, so it develops when there's obviously too little sodium, and the causes are vomiting, diarrhea, overhydration, syndrome of inappropriate secretions of ADH, SIADH, as medications like diuretics, anti-epileptic medications, carbamazepine is linked to the causing hyponatremia. Alcohol use disorder, I mean, if somebody is frequent boozer, then it will cause hyponatremia. Any thyroid, hypothalamic, or any adrenal disorder also cause hyponatremia. The second electrolyte would be potassium. Normal range, as you know, it's from 3.5 to 5.5. And hyperkalemia, obviously, basically we need to know potassium is it's important for regulating the heart functions. It also helps maintaining the healthy nerves and muscles. So obviously hyperkalemia develops when there's a high level of potassium. It could be fatal, and the condition is fatal if it's left undiagnosed and untreated. So the causes are, again, severe dehydration, kidney failure, severe acidosis, including the diabetic ketoacidosis. Medications, so these medications are linked with hyperkalemia, spironolactone, that's potassium sparing one, ACE inhibitor, ARBs, NSAIDs, even the tacrolimus. Hypokalemia, it occurs when obviously potassium levels are very low, low beyond the range. This happens as a result of, severe vomiting, diarrhea, dehydration again, eating disorder, medications like overuse of diuretics, overuse of laxatives, insulin overdose or overuse, and corticosteroids. I would say the third is calcium. The range is from 2.1 to 2.6 millimole. Hypercalcemia. So basically, we need to know calcium. It's one of the vital mineral which that our body utilizes to stabilize the blood pressure and controls the muscle contraction. It's also used to build strong bones and health teeth. So hypercalcemia occurs when, obviously, when you have too much of calcium in the blood. It's caused by kidney disease, hyperparathyroidism, lung disease like sarcoidosis, tuberculosis, multiple myeloma, excessive use of calcium as a vitamin D supplements, and some medications like lithium, those with a narrow therapeutic index like lithium, theophylline, thiazides, thiazide diuretics. Hypocalcemia, obviously, when the level is, when there's a lack of adequate calcium in the bloodstream. Again, the cause would be kidney failure, hypoparathyroidism, vitamin D deficiency, pancreatitis is associated with hypocalcemia, malabsorption, and the certain medications like phenytoin, phenobarbital, rifampin, bisphosphonates, calcitonin, and chloroquine. Another would be phosphate. The range is from 1.1 to 1.45. I mean, it depends on the different trust, but normally we try to keep it above 1. Yeah. Phosphate. So basically, the bones, kidneys, and intestine, they work to balance the phosphate level in the body. And phosphate is necessary for varieties of functions and interacts closely with the calcium. So hyperphosphatemia, it occurs when there's a low calcium level. It occurs due to chronic kidney disease, underactive parathyroid glands, severe muscle injury, and tumor lysis syndrome. It's a complication of cancer treatment. Likewise, hypophosphatemia, low levels of the phosphate, it's seen in acute alcohol use when there's a severe burns, again, 3rd degree, 4th degree burns, 2nd degree, even from in 2nd degree also. Overactive parathyroid glands, vitamin D deficiency, and some medications like thiazide and corticosteroids. So these are the 4 electrolytes that I've mentioned. Likewise, there are other electrolytes like chloride, magnesium, which I haven't mentioned in the slide, but I can go through it. Chloride, again, it's necessary for maintaining the balance of the bodily fluids. Hyperchloremia occurs, obviously, when there's too much chloride in the body. It could be because of, again, dehydration, kidney failure, dialysis. And hypo is when there's little chloride in the body. The causes could be because of either sodium or the potassium problems. Along with that, hypochloremia is also seen in the cystic fibrosis, eating disorders like anorexia nervosa and AKI. And another electrolytes would be magnesium. It's one of the minerals that regulates many important functions like contraction, muscle contractions, heart rhythm, nerve functions. So again, it's divided into both hypermagnesemia and hypo. So hypermagnesemia disorder, it primarily affects the people with Addison's and indistinct kidney disease, whereas hypomagnesemia means having a little magnesium in the body. Hormone causes includes again, alcohol overuse, malnutrition, malabsorption, chronic diarrhea, excessive sweats. So these are the general electrolytes that I've just gone through. Now, how we treat the electrolyte disorder basically is like always treat the underlying cause. Whatever the cause is, just treat the underlying cause. If we treat the underlying cause, mostly it gets corrected. Depending on the electrolyte disorder, you have to give either IV fluids, you have to give oral medications, sorry, supplements, and like supplements like calcium, depending on which electrolyte is deficient. And last resort would be hemodialysis. Thank you very much. That's me.
Any questions for Jagdeep?
Looks like there's
Jagdeep,
no question.
That was a very good presentation.
Thank you very much. Thank you very much.
If you ask a question. Sorry, I can hear some echoing around. So, does anyone have any doubts for Jagdeep? Feel free to ask now. It was a very good presentation, Jagdeep. I can collect some good learning points from your presentation. First is acute versus chronic kidney disease. acute kidney injury, or rather, there is no specific differentiation between the two.
Mhm.
It is only when the renal function has deteriorated in, I think, 24 to 72 hours.
Yeah.
It is termed as acute kidney injury.
Mhm.
As chronic kidney injury is said to be ongoing renal disease with deranged renal function and electrolyte levels.
Yeah.
And in presence of chronic kidney disease, if you have any further new changes in electrolyte or metabolic or renal function levels, then it is still called as AKI on CKD.
Yeah.
Okay. Um, you mentioned three causes, that is pre-renal, renal, and post-renal. Majority of the post-renal causes are treated surgically, or rather, they are reversible.
Yeah.
As far as renal cause is concerned, quite a number of issues are irreversible,
Mhm.
and maybe medical management or lifelong renal replacement therapy is required in these cases.
Mhm.
As far as pre-renal is concerned, uh, a simple way to remember is that the kidney is not at fault. It is something happening before reaching the kidney that gives trouble to the kidney.
Yeah.
So which actually means your urea and creatinine levels will start increasing in a proportionate manner, and the filtration function of kidney is normal. So that is why your urine sodium level will be normal to low in pre-renal cause. And there are, like, you have listed a number of factors, but I will say for pre-renal itself, there are infinite number of causes for kidney to get damaged,
Yeah.
and almost every patient is vulnerable for renal dysfunction for any kind of surgery or any kind of stress that he or she passes through.
Mhm.
So that is why pre-renal, which is always reversible, has to be treated as quick as early as time. I think it was in 2019, Kedigo had shown some observations and suggestions. Okay.
Mhm.
So
Mhm.
of whatever the procedure you're going through, whatever disease, try to target a mean arterial pressure reasonably above the renal perfusion pressure level.
Mhm.
Okay. And, and that is the only nephroprotective technique that has been documented so far.
Mhm.
And if I want to maintain mean arterial pressure above, let us say 60, 65, whatever the target you want, first, always ensure that you have a good circulating blood volume. Second, afterwards, try to correct the pressures using inotropes or vasopressors.
Mhm.
And third, preferably to maintain a good cardiac output, which is why after every complex surgery, in our units, you must have seen we are using either PICO or LIDCO. In Ealing today, I have seen PICO monitor, uh, and otherwise in Northwick, we are commonly using LIDCO. You can use any kind of goal-directed therapy, but it has to be like you should be well confident while managing them. Next, we will quickly highlight about electrolyte disorder. Uh, uh, whether it's low or high, uh, whether it's low or high, uh, most of the time low electrolyte levels are quite concerning for us,
Mhm.
except if it
Potassium.
is very high, obviously it will be fatal. And almost every cardiac arrest is associated with high potassium level.
Yeah.
So phosphate, I will say that a patient who has been fasting for more than 24 hours will have all the pathophysiology of starvation happening, and reintroducing enteral nutrition suddenly for such patient can cause sudden hypophosphatemia, which is said to be equally fatal because it can cause arrhythmias. Similarly, always maintain potassium level in within the normal range, because when you're seeing serum potassium level, it is reflecting the intracellular pathology in, or rather intracellular environment in general. So if your potassium levels are low, take it for granted along with potassium, magnesium level also will be low.
Okay.
So that is, you need to maintain a good intracellular environment. First, always correct potassium. If you have strong reasons to believe, definitely correct magnesium as well at the same time. Otherwise, there is a risk of arrhythmias in these patients.
Mm-hmm.
Same thing is with calcium level as well.
Yeah.
Okay. I said we will discuss about blood gas, but I don't think we have enough time. Okay.
Okay.
So,
Okay.
Siddhant, you can go ahead, start sharing your presentation. I will keep the presentation on my side as mute because I am getting frequent calls on this end.
Sure.
So, Siddhant, over to you.
Yeah, can you guys see my slide?
I can see your slides. No. I cannot see your slides. Sorry. It is Jagdeep.
I'll try to share again. How about now?
Yes,
Yeah,
Siddhant, we can, yeah, we can see your slide now. Yeah.
you can start with your presentation.
Yeah. Hi, I'm Siddhant Jha, one of the assessors in ITU. The topic of my presentation today is AKI and renal replacement therapy. Talking about the AKI, my colleague earlier already said something about acute kidney injury. I'm going to add some more to that. Acute kidney injury is basically caused by a rapid deterioration in the kidney function. And it can be defined by the following criteria. Increase in serum creatinine for more than or equal to 26.5 millimoles per liter within 48 hours, or increase in serum creatinine more than or equal to 1.5 times the baseline of the creatinine of the patient, which is presumed to have occurred within the prior 7 days, and urine volume less than 0.5 ml per kg per hour for 6 hours. In these cases, in any of these cases, the patient can be diagnosed as acute kidney injury. The staging of AKI in stage 1, stage 2, and stage 3, and these are the criteria of the staging. Stage 1 AKI is 1.5 to 1.9 times of baseline increase, or more than or equal to 26.5 millimoles per liter of serum creatinine, or urine output is less than 0.5 ml per kg per hour for 6 to 12 hours, that is stage 1. Similarly, if the serum creatinine rises 2 to 2.9 times more than the baseline, then and urine output is less than 0.5 ml per kg per hour for more than or equal to 12 hours, that's stage 2. And stage 3 is 3 times the baseline rise in serum creatinine, or serum creatinine rise to more than or equal to 350 millimole per liter, along with urine output less than 0.3 ml per kg per hour for more than 24 hours, or anuria for more than or equal to 12 hours. That is stage 3. In patients less than 18 years, decrease in EGFR less than 35 ml per minute is considered as stage 3 AKI. So the causes of AKI, it has already been mentioned. I will just quickly go through this. Basically, there are 3 causes: pre-renal, intrarenal, and post-renal causes. So the pre-renal causes, the main cause is because of the reduced perfusion to the kidneys. And that could be because of absolute hypovolemia, such as in hemorrhage or overdiuresis, vomiting diarrhea, low effective arterial blood volume. What this term means is there is not much effective blood supply, which is actually giving perfusion to the kidney arteries in the kidneys. So that could also cause the AKI, and these are basically causing heart failure, cirrhosis, sepsis, anatomical causes like renal artery stenosis, which can also cause reduced perfusion to the kidneys, and some drug-induced AKI like
Siddharth, I think we've lost you. We can't hear you.
Hello?
Yeah, now we can hear you.
Oh, sorry, there was a disruption in the internet connection.
No, it's all right. It's okay.
So, as I said, the intrarenal causes are acute tubular necrosis, acute interstitial nephritis, glomerular disease, intratubular obstructions. These were also explained by my previous colleague, Jagdeep, so I'm not going to go in detail in this. And post-renal cause, basically the obstructive pathology is the main cause for the post-renal AKI, which can occur in these levels like ureters. It can cause nephrolithiasis, retroperitoneal fibrosis at the bladder. Patients can have bladder cancer. Benign prostatic hyperplasia and prostate cancer can also cause obstructive pathology. Urethral strictures. Obstruction at or distal to the level of bladder can cause a post-renal AKI in both kidneys. And unless there is a solitary kidney, a unilateral obstruction may not cause post-renal AKI, as the unaffected kidney may be able to compensate for the reduced function of the affected kidney. This puts patients with a solitary kidney at risk of AKI. Now let's talk about the at-risk groups and susceptible groups for AKI. So patients more than 65 years of age who has already got patients with CKD and the comorbidities like cardiac failure, chronic liver disease, diabetes, cancer, vascular disease, dementia, volume depletion, trauma, organ transplantation patients, immunosuppressed patients, and the patients who had major surgery, especially open laparotomy, and post-contrast AKI is also common. So these are basically at-risk groups for AKI.
Siddhant, can I interrupt you for a second? I am not able to see your slide.
You are not able to see my screen?
No.
How about now?
Better.
Thank you. Sorry for the disruptions. So let's talk about the investigations that we do in AKI. So the common laboratory investigations are look for urea and electrolytes, full blood count, liver function test, venous blood gas. These are pretty basic investigations which give us a lot of information and which actually guides us in which direction we need to go. And urine studies like urine analysis gives us idea about if the patient has got proteinuria, albuminuria, hemoglobinuria, hematuria, if there is WBC is in the urine or glucose. So these are quite valuable in diagnosing the patients. Urine volume measurement can give us idea about oliguria and anuria. Microscopy and sedimentation like gas and crystals can also give us idea about the diagnosis. Urine osmolarity and specific gravity that can also give us idea about dehydration, but it is less commonly used in clinical practice. Similarly, urinary eosinophil count is useful in evaluation of acute interstitial nephritis, but it is less commonly used in clinical practice. Similarly, the imaging studies are valuable as well in diagnosing AKI, mainly to find out if there is any obstructive cause or not. So post-void residual volume can be assessed rapidly using bedside bladder scanner. Ultrasound of kidneys, ureters, and bladders assesses the kidney size, hydronephrosis, post-renal obstruction, renal lesions. It can also help us to find out the corticomedullary differentiation in the kidneys, which is one of the hallmarks to diagnose CKD. So in chronic kidney disease, the corticomedullary differentiation is lost. So ultrasound is helpful with that as well. CT non-contrast usually helps us to find out radio-opaque or non-radio-opaque calculi, ureteric obstruction. CT urogram, CT triphasic kidneys, which is cross-sectional imaging for renal lesions, often used to clarify the masses seen on ultrasound. A renal biopsy is not usually performed, but it can be considered for suspected intrarenal AKI or suspected rapidly progressive glomerulonephritis. Where ATN is clinically suspected, a renal biopsy is usually not undertaken unless specifically trying to exclude a reasonable alternative diagnosis. Management of AKI. So we have been managing AKI on our day-to-day basis, and it is quite common in hospital. I'm just going to emphasize on key factors for the management. First of all, withdrawal of the nephrotoxic medications. We need to check the drug chart if the patient is on any nephrotoxic medications like ACE inhibitors, ARBs, diuretics. If patient is diabetic, they may be on metformin. We should look for NSAIDs and so on. So we need to make sure that we have held all the nephrotoxic medications. Adjustment of the drug, doses of the drugs, because there are many drugs whose doses needs to be changed according to the renal function. So we need to be cautious about those things as well. Fluid resuscitations can rapidly improve renal function in hypovolemia and hypotension. So that is also very important to treat pre-renal AKI. Urinary catheterization can be used where there is difficulty in measuring urine output or to relieve the urinary obstruction. Assess for evidence of sepsis and initiate the sepsis care bundle if required. And as we know that AKI is very, very common in patients with sepsis, so we should follow the protocol, sepsis protocol, whenever needed. So this is ABCD checklist. So basically, it helps us to remember easily what we need to do if we have a patient with AKI. Address drugs, boost blood pressure, give IV fluids, calculate fluid balance, urine dip, and exclude obstructions. So these are basic things which we discussed earlier for management of AKI. And these are some medications which are commonly used in the patients, which may be a patient may be taking these medications which are nephrotoxic, and they usually either alter EGFR alteration, tubular cell toxicity, interstitial nephritis, and crystal nephropathy. So these are the basic effects of these medications, which could lead to AKI. Last but not the least, there are complications of AKI which needs to be addressed as well. So hyperkalemia seems to be one of the most important complications, which is quite fatal as well. And hyperkalemia can be treated with insulin, glucose doses, with calcium gluconate whenever it is indicated. So we need to treat hyperkalemia. Patients may have low urine output and they may go into fluid overload, which can be treated with furosemide. They are also high risk at getting metabolic acidosis. So initially we could use some bicarbonates to treat metabolic acidosis, but if it is refractory and if it is not improving, then we need to consider for renal replacement therapy. Talking about the renal replacement therapy, basically the renal replacement therapy is the replacement of function of kidneys, filtration and movement of electrolytes and fluids in and out of the body. It is common form of organ support in critically ill patients. The idea is to support the function of the injured kidneys to allow time for repair, which occurs in most patients. The basic functions of kidneys are control of extracellular fluid volume, osmolality and blood pressure, electrolyte balance, acid-base balance, eliminate waste, creatinine, urea, toxins and drugs, and hormone production. So renal replacement therapy replaces only non-endocrine kidney functions. The indications of renal replacement therapy, basically it is indicated in more severe cases of AKI, like fluid overload resistant to diuretic therapy, metabolic acidosis, PS less than usually 7.15, refractory to medical management, hyperkalemia, potassium more than 6.5, refractory to medical management, patients with uremic symptoms like encephalopathy, pericarditis, and bleeding diastasis. Other important indications are poisoning with a dialyzable drug or toxin. So renal replacement therapy can help us to take that out. Hyperthermia, refractory to regular cooling techniques. So cold dialysis. So they actually use regulate the temperature of dialysate to treat the hyperthermia during the dialysis. Life-threatening electrolyte derangements, obviously, that we discussed earlier, and progressive azotemia, oliguria, unresponsive to medical management. All of these renal replacement therapy can play a pretty important role to help save patients' life. So there is a mnemonic for renal replacement therapy, AEIOU. So acidosis, electrolyte abnormalities, ingested toxins, fluid overload, uremia, and additionally, oliguria or anuria will often accelerate the need for renal replacement therapy. I would also like to talk about the dialysis circuit a bit, the way the dialysis is done here. So first of all, this is vascular access. If the patients are doing regular maintenance dialysis, they may have arteriovenous fistula, but in critically ill patients with AKI, usually the central venous catheters are usually used for the dialysis. This is a blood pump in the dialysis circuit, which pumps the blood with a certain pressure. This is a dialyzer. Dialyzer is a rigid case that encloses thousands of semi-permeable polymer tubules. And this is dialysate. Dialysate, it is a solution, isotonic solution containing electrolytes, bicarbonate, glucose. The dialysate solution is chosen to match the serum osmolality. And the blood is passed through the blood pump, through the dialyzer, and dialysate is passed through here again. And the process of ultrafiltration takes place at this place through transmembrane pressure gradient, and basically the osmosis takes place, and all the electrolyte abnormalities and impurities are taken out here, and then it is excreted as effluent and collected in this container, and the filtered blood is sent back to the body through the same catheter. And if we do not need to take out ultrafiltrate, then there is a replacement fluid which actually compensates for the ultrafiltrate. So basically, this is how a dialysis process occurs. This is a brief explanation. However, it is actually more complicated than this, but I'm just trying to explain it in a brief manner. So ultrafiltration is basically the filtration of water from the blood driven by transmembrane pressure between the blood and effluent. Yeah. And these are the different types of modalities of RRT in the ITU, commonly used in ITU. First one is intermittent hemodialysis. Basically, it is done in 3 to 5 hour session using a standard hemodialysis machine. It is commonly done with chronic kidney disease patients who basically usually has arteriovenous fistulas or graft, or CVC. The blood flow and the dialysis flow here is very high. As we can see here, they are pumping with a very high rate, and the clearance is highest and ideal for hyperkalemia or toxins to remove with this kind of dialysis. However, the side effects are quite common in this process. Hypotension because of rapid removal of ultrafiltrate, so there is always risk of hypotension. And another risk is disequilibrium syndrome. What this means is patients who has got uremia and we try to correct the urea rapidly, then they may develop some neurological signs and symptoms. So those series of signs and symptoms like confusion, coma, convulsions, nausea, vomiting, fatigue. So these side effects are called basically disequilibrium syndrome. So this is very common with intermittent hemodialysis. Another one is sustained low efficiency daily dialysis, which actually occurs 12 hours using standard hemodialysis machine. The blood flow and dialysis flow rate is lower than that of the intermittent hemodialysis, and clearance is moderate, causes comparatively less hypotension, and there is risk of hypophosphatemia in this kind of dialysis. And one of the important benefits of using this kind of dialysis is that it is very cost effective and less time consuming than CRRT. So it could be utilized for more patients if required, because sometimes in many places we may not have sufficient number of dialyzing machines. So SLADE could be a very good option in those cases. Another one is continuous renal replacement therapy. It usually occurs 24-hour session with CRRT machine. Basically, the rate is lowest in this kind of dialysis, ideal for slower correction of abnormalities and fluid removal, causes least hypotension. However, patients are immobilized and there is high risk of thrombosis. There is also risk of clots while in the process of dialysis in this kind of dialysis process, and it is higher in terms of cost as well. There are some more subdivisions of CRRT mode. First one is slow continuous ultrafiltration. Ultrafiltrate is removed, filtration removes fluid but provides almost no clearance and does not correct pH. No replacement of fluid required, corrects volume overload only. CVVH is continuous veno-venous hemofiltration, provides convective clearance by filtering a large volume of blood. Replacement fluid restores volume loss, corrects uremia, electrolytes, pH, and can remove volume as well. Third one is CVVHD, continuous veno-venous hemodialysis, provides diffusive clearance of running dialysate opposite to the blood flow. No replacement fluid is used, gently corrects uremia, electrolytes, and pH. And the last but not the least, CVVHDF, which we have also seen being used in our ITU setting. Continuous veno-venous diafiltration. So high clearance is achieved using both ultrafiltration and dialysate flow. Both convection and diffusion process is used, plus replacement fluid is used. It allows fluid removal, correction of electrolytes, pH, and good for toxin removal. The next thing to discuss here is regarding the anticoagulants that are being used while the dialysis. Citrate is, however, the most commonly used anticoagulant in critical care setting. However, we need to be very, very cautious while using it with patients with acute liver failure, because citrate is metabolized in liver and there is a potential risk of citrate accumulation. Citrate can be used, but unexplained rise in lactate should prompt reevaluation and a change to either heparin anticoagulation or use of no anticoagulation should be considered in these cases. The next one is heparin. It is basically used when there is citrate intolerance, poor filter lifespan associated with citrate, and hypernatremia patients. So citrate has a tendency to worsen the hypernatremia. So heparin anticoagulation should be used if there is contraindication to use of citrate, basically. And no anticoagulation is used in patients who are already systematically anticoagulated with has contraindications to citrate. No anticoagulation should be used if the patient is already systematically anticoagulated, achieving desired INR or APTR, and citrate is contraindicated. However, in patients with suitable for citrate, it can still be used in presence of treatment of those anticoagulant given that citrate exhibits no systemic anticoagulant effect. Now I'm going to briefly talk about START AKI trial, which is the largest trial to inform us about the timing of RRT in critically ill patients. The trial demonstrates a sound methodological approach while more accurately reflecting current practice in critically ill patients with AKI. There has been many other studies, but this trial is used as the most effective ones among others, as it has larger sample size and many. It was done internationally, included many other communities of ITUs as well. So the clinical question while doing this START AKI trial was, does the initiation of an accelerated or standard renal replacement therapy result in lower risk of death from any cause at 90 days in critically ill patients with acute kidney injury? So accelerated strategy means clinicians were to start RRT as soon as possible and within 12 hours after the patient had met full eligibility criteria. Standard strategy means clinicians were discouraged to start RRT unless development of one or more of the following criteria, that is serum potassium less than 6, pH 7.2 or less, bicarbonate of 12 millimole per liter or less, or evidence of severe respiratory failure. And I would also like to discuss about the inclusion criteria briefly. So the patients should be 18 years and older, admitted with kidney dysfunction, creatinine more than 99 in women, creatinine more than 129 in men, with severe acute kidney injury defined by kidney disease, improving global outcomes of kidney classification as doubling of creatinine level from baseline, serum creatinine more than urine output less than 0.5 ml per kg per hour. So these were the inclusion criteria. And as I said, the method was multinational, randomized, and included a large number of groups for the studies. So it is considered as the most effective one. So the conclusion of this AKI trial was the decision to initiate early RRT versus standard therapy in critically ill patients with acute kidney injury has not shown any mortality benefit at 90 days. Patients that in accelerated arm were more dependent on RRT at 90 days and had more adverse events. And multiple studies have validated these findings and sort of acute indications of RRT. Medically, managing these patients appears to be the best strategy in an effort to delay the RRT. So basically, the START AKI trial is mentioning that starting the RRT in the patients does not really has got much effect at the end of 90 days, and we should focus on managing the patients medically as much as we can, unless there is absolute and indication, and if there is no option to go for RRT, then only we should do RRT. That's what this trial says. Thank you so much for listening to my presentation.
Thank you very much, Siddhant. Anybody, any questions, any doubts or suggestions? No doubts? Okay, Siddhant, it was a very good, very extensive topic. Okay, we've got Saraa also here. Saraa is our senior pharmacist in the unit in Northwick Park, and she's going to present. Sorry, Saraa, I forgot your topic because there was a mixing of 2-3 topics together.
Yeah, it's prescribing errors in ITU. So I'm just trying to upload my presentation now.
Okay.
Let me know when you can see it. Can you see it now?
Yeah, we can.
It's good prescribing tips and prescribing errors, just so that we can learn from previous prescribing errors and not fall in the same trap. If you have any questions, just feel free to unmute and ask straight away. I'll try and be quick. I know I've got 40 slides, but I'll go through them relatively quickly. There's a few where I'll ask you for your engagement, so please interact, because this is for you to reflect on as well. So sorry to bore you. Yep.
Sorry, because I will be on call right now, if that's okay.
That's okay. That's fine. You need to head out then.
Yeah, I am recording at the same time, so I will be listening to your presentation.
That's fine. Okay, so a few prescribing rules to note to start off with. Please write in capitals. Please use black ink. Don't write RU next to a number or below it. So don't write it like this and don't write it like this. Write it with sticks and units underneath it. And if you have an antimicrobial, please write the indication and duration on it. That's a daily question that we have every day as to why this antibiotic was started. These are your guidelines that you have on the internet. We have a drugs guide in adult critical care, which has a summary of all the common prescriptions that you prescribe, and the ITU renal dosage guide. So thank you to the previous presenter for presenting on CVVH-CF and renal replacement. We have how to dose these based on literature that we've gathered. So you see in this document, we have laminated sheets at every ops chart. If there's an ops chart that's missing, then please let me know, but please keep it safe in your phone as well. It's literally gold dust, because it's got all the prescriptions that you'll be asked to prescribe that have weird and wonderful preparations, and it even has the dose range for you. All you have to do from a prescriber's perspective is set the target for the nurses. So you set the target for, say, sedation. You want the RAS to be -2, -3, or 0, and then prescribe the drug, and the nurses will titrate it up and down according to your target that you've given them. This is the renal dosage guide. So it's got the common drugs that we need to adjust. It's got what the BNF dose is. And if you're on CVVH-CF on an effluent dose of greater than 35 mils per kilo per hour, this is a dose that you should recommend. And if you're not on the filter and your creatinine clearance is less than 30, less than 20, or less than 10, then you use these 3 columns at the end. Again, I've shared that with the WhatsApp, and it's available on the intranet as well. This safety alert is an important alert to share. It's regarding sodium valproate, which is teratogenic, and we use sodium valproate very regularly for seizures. And what it's telling us is basically to do pregnancy tests on anyone that we prescribe sodium valproate 2. So if you're of childbearing age, that's between 13 to 55 years of age, then you have to carry out a pregnancy test if the pregnancy test comes back positive. So your clinical discretion as to whether you want to give it or not give it, but the risk is you will cause teratogenicity to the unborn child. If the pregnancy test is negative, then it's safe to give. There's a memo that I'd like to share with you about heparin. We're short of the heparins. We used to have 25,000 unit ampules, and now we have 20,000 unit ampules. And depending on which supply we get, we might get the 25K or the 20K. But depending on which one we have at the period in time, we literally have no control over it. Please adjust your prescription accordingly. Because there's two protocols out there, one for the 25K and one for the 20K. And the difference between them is they're two different dilutions with two different concentrations. So the 25K has a concentration of, let me try and figure out which one's which. This confuses me as well. One has a concentration of 1,000 units per mil. One has the 25K has a concentration of 500 units per mil, and the 20,000 K has a concentration of 1,000 units per mil. So the protocols are different, and when you're trying to target an APTTR of 2.1 to 2.5, the volumes that the nurses need to change are very different. So when prescribing heparin, always just double check which heparin is available, so you can choose an appropriate prescription for that patient. We have had at least 3 lasexes with this confusion between the two heparins. Another issue that we've had is if someone is on heparin via the filter for anticoagulation of the renal replacement circuit, and they're also prescribed heparin subcut as a VTE prophylaxis. What happens is sometimes these are double dose. What should happen is when you're on heparin via the filter, the nurses target an APTTR of 1.5 to 2, and that APTTR of 1.5 to 2 is sufficient to give the patient VTE prophylaxis. The nurses measure it, and if it's low or high, they adjust their heparin dose via the filter accordingly. So technically, the heparin subcut for VTE prophylaxis by the patient should be withheld on the days that they're receiving heparin via the filter. We've had a few incidents with insulin. So this patient got admitted to ITU, and while washing them, Mr. Y became agitated and pulled out his NG tube. When the NG tube was stopped at 11:30, while the NI nurse in charge was doing her evening rounds, it was noted the insulin infusion was still running despite ongoing NG feed. The patient's blood sugars dropped to 2.4. So the insulin infusion was immediately stopped and glucose 20% was given. Their blood sugars were monitored closely overnight. The NG feeding was started as soon as the NG was confirmed in situ. And normal practice should be to stop the insulin as soon as the feed stops. So this is a scenario where it's mainly like the nurse's prerogative. But from your perspective, if you order the nurses to hold the NG feed, your following order should also be to hold the insulin as well if they're on an insulin infusion. These are some common insulin errors that we've had. We've had incorrect regimens prescribed, and I'll go into detail as to which one. We've had the long-acting insulin not prescribed to patients with DKA. So with DKA, they've got their DKA protocol, but the long-acting insulin should always be prescribed as well. With respect from the nurse's perspective, we've had poor blood glucose monitoring, where they're monitoring it 4 hourly, and they should monitor it every hour. So if you see that missing in the off chart, please prompt your nurses. This one is a repeat of the incident that occurred before, where the insulin infusion was continued while the patient's feed was on hold, leading to hypoglycemia. We've had U written next to the number of units, and the patient ended up getting 20 units of insulin instead of receiving 2, and that resulted in hypoglycemia. We've had disconnection of the infusion, and that's not a doctor's fault. That was mainly nursing, but it's good for you to be aware of all the errors. So in our protocol for insulin, we have 2 protocols. We've got the variable rate insulin infusion, which is mainly for level 2 patients. And this is the criteria for giving it. I find it easier to remember the tight blood glucose algorithm, and everyone who doesn't fall in this criteria gets to be given the variable rate insulin infusion. So the tight blood glucose algorithm for ICU patients is mainly all level 3 patients if they're on any inotropes. if they're on PN, if they're sedated, whether they're paralyzed or not, if they're septic and on steroids, and then this isn't a criteria, but you require to be to have an arterial line for monitoring if you're on the type blood glucose regimen. Everyone else should go on the variable rate insulin infusion, but the majority of our patients fall under the type blood glucose window. So how you as a prescriber would request it is you would sign this prescription and you would tick type blood glucose if they're level 3 patients, or you would tick variable rate insulin, intravenous insulin infusion if they're the level 2 patients according to the criteria. When you pick that, then you need to pick which scale they should be on. They could be on scale 1, scale 2, or scale 3. The drug chart is being updated to match the protocol, and the target up here says 4.5 to 10. It should say 6 to 10, so that the nurses and the pharmacists and the doctors can also amend that. That's just reiterating the target. If the patient's BMs fall below 6, you stop the insulin infusion and monitor BMs. If they fall below 4, then you stop, then you treat as a hypoglycemia, and the nurses are expected to day-text that. Okay, now I'd like some interaction from the audience. Can anyone spot the prescribing error here? You can type it in the chat, or you can unmute and tell me. Okay, for the sake of time, I'm going to answer it. So in this situation, the patient allergic to penicillin is given tazocin. This has happened quite often, and unfortunately, we always have to double check the allergies, not just for antibiotics, but for all medication. So always check the patient's allergies. We've had a fatal SI with a patient who was given penicillin and 3 days later developed Stevens-Johnson syndrome and unfortunately died. I know there's a lot of fake allergies out there with patients who claim that they're allergic, but you think they're not allergic. But we have a referral system here where you can refer them to the penicillin allergy testing clinic at Northwick Park, and they can get tested after they get discharged from ITU, and that way in future readmissions, then that allergy would be deleted. Please carry this this on your lanyard. I'll put some in the doctor's office. It's got all the red drugs here, the ones you should avoid if you've got a penicillin allergy that's severe, like anaphylaxis. The yellow ones here is if you've only got like a rash, then you can still kind of get the cephalosporins and the beta-lactams, like the meropenams and the ertapenams. And then the green ones are the safe ones to give. Due to handwriting, there's sometimes confusion where the U next to units or the I next to units can be confused for a 0 or a 1. So please avoid putting a U or an I next to a number, because we've had lots of errors where 10 times a dose was given, and the patients suffer at the end of the day. So if you're prescribing heparin for VTE prophylaxis, do not prescribe it as heparin 5,000 units with the U next to the 0. The units needs to be underneath it and not adjacent to it. The same applies to insulin, and the same applies to neurocormin. These are the common ones that we prescribe in ITU. Can anyone spot this error here with ticaplanin? So the hint is that the patient weighs 95 kilos. Okay, so it's it should be at least 6 milligrams per kilogram. So if you're 95 kilos, you're almost 100, then you just round it up to 600, and you give 600 milligrams BD for 3 doses, then once a day. And what happened in this scenario is the patient was underdosed and then kind of overdosed, because the BD prescription continued to be given throughout. You should cross out one of the doses. So what you count 1, 2, 3, and you cross out the evening dose thereafter. And that's how you prescribe ticaplanin. We had an issue with prokinetics where the consultant ordered erythromycin to be given as a prokinetic for a patient, and the patient was prescribed clarithromycin. They do sound alike. So our first line prokinetic that we use is metoclopramide, and the reason why we avoid antibiotics is to prevent antimicrobial resistance, which is a worldwide problem. Then if the metoclopramide doesn't work, then you add in the erythromycin at 250 TDS, and you always monitor for QTC. Oh my Lord, apologies for this. This is an error. This is just the answer to the previous one. This slipped in somehow. Can anyone spot the error here for meropenem? So this isn't an error per se, but it's mainly for good prescribing. With this prescription, midnight was put at the top end of the prescription rather than at the bottom. And yes, the day does start at midnight, but unfortunately what happened is that patient missed that dose because visually when the nurses see the prescription, they see morning, afternoon, and nighttime. And the night nurses looked at the 8 o'clock dose, the 1600 dose, and they didn't see anything underneath it. So how we'd like you to prescribe a prescription for midnight is to just have what the morning nurses give in the morning and what the night nurses give at night. And if you push the midnight dose to the latter part of the prescription, and that would prevent that prescription from being missed. And missing antibiotics, as you know, is not good for septic patients. Ciprofloxacin. So in this patient, the patient was prescribed ciprofloxacin for HAP. The prescription was given as 400 IV/NG TDS, and it was prescribed 3 times a day. In this scenario, the patient was actually not absorbing via their NG. So the prescription was intended to be given IV. And the nurse went ahead and because they saw NG, they're in their head good antimicrobial stewardship is to give stuff via NG. So the nurse went and gave the 500 milligram tablet, dissolved it, and managed to get 400 milligrams out of that and gave it to the patient. So now, one, the patient is not absorbing, and two, the dose is different for the NG. The dose for the NG should be 500 BD, or if you want the higher end of the dose, we give 750 milligrams BD, and the dose for the IV is 400 milligrams BD, or 3 times a day. The 400 milligram IV is bioequivalent to the 500, but that is if you're absorbing. If you're absorbing, then you can match them. If you're not absorbing, then we prefer for you to give the IV straight away. We've had lots of problems with lookalike, sound-alike drugs, so this is why we say please write in capitals. If you don't write in capitals, you put your prescription at prone to error and being misinterpreted and misread. So we had a patient who was given cefuroxime 2 grams BD when the intention was to give ceftriaxone 2 grams BD, mainly because they look alike, and the spelling, if you're writing joints up together, they can be very easily confused. So one, the ceftriaxone was for meningitis. It has good blood-brain penetration. Cefuroxime is not for meningitis. It has poor blood-brain penetration, and the patient overdosed on cefuroxime because the maximum dose of that is 1.5 TDS, not 2 grams BD. There's another sad scenario of a patient who was, the intention was to give flucloxacillin 1 gram 4 times a day, and they received fluconazole 1 gram 4 times a day, and that was again an overdose, and it was put down to handwriting again. And there was another prescription that was for clopidogrel stat, and the patient was given clonidine 300 stat. So if you just write in capitals, it would help prevent errors such from occurring. It's good to be mindful of look-alike, sound-alike drugs. So all the cephalosporins look alike and sound alike. And I've been a pharmacist for a couple of years, and I always double check every time I see a cephalosporin because I know it's prone to error, and double check the dose and the duration. The other things that look alike, sound alike are the magnesium, sodium, and water. And we had an incident in ITU where the doctor wanted to flush a line with saline, and the doctor went to the bedside drawer and picked up what they thought was saline, actually they picked up magnesium and flushed the magnesium, and the patient went hypotensive, and they needed to increase their NORAD, and they went. It was just the patient deteriorated at that moment because you're not supposed to give magnesium as a bolus. Because of its hemodynamic effects that it can have. So be mindful of these drugs that look alike, and they can be just sitting in the drawer by the bedside. And always get someone to double check you when you're administering an IV. Here is some more look-alike, sound-alike drugs. I'll just give you a minute to go through them. Okay, minute over. So how to prevent errors? Please always write in capitals. Please be vigilant when prescribing lookalike standard-like drugs. So we have a few patients that don't have a CVC line, and that's if you're just a level 2 patient, and you have a pre-printed prescription for potassium, which needs a CVC line because we use this concentrated potassium that's 40 millimoles and 100 mils. And in this scenario, the patient was given the potassium via peripheral line, and the patient screamed in agony from the amount of pain that it caused to them. Plus, you can predispose the patient and put them at risk of a cardiac arrest if you infuse it too fast or too slow. So concentrated potassium should always be given centrally, and the maximum concentration for peripheral is 40 millimoles in a liter, or in fluid-restricted patients is 40 millimoles in half a liter. I've already mentioned this point. If you're giving potassium, whether it's by CVC or by peripheral, the maximum rate is at 20 millimoles per hour with ECG monitoring. This is a scenario where a patient was prescribed aminophylline and the prescription was given according to their actual body weight of 120 kilos, but their ideal body weight is 60 kilos. The aminophylline loading dose should be 5 mg per kg, followed by 0.5 mg per kg per hour. So as you can imagine, they were because of their high BMI, they were given 600 milligrams bolus, and then if infusion was given at 60 milligrams per hour, they should have been given 300 milligram bolus followed by 30 milligrams per hour, so literally double the dose. Their theophylline level did come back high, and we had to readjust the dose and bring it down. So please be mindful of drugs that are dosed based on ideal body weight. If you're not sure, we always have a protocol. There was a situation where a patient was on chronic fentanyl. When they came to ITU, they were intubated, sedated, and ventilated. They were on a fentanyl infusion, so the fentanyl patch that they were on from prior to admission was withheld. Then when they were extubated, the fentanyl infusion was stopped, and they were put on a PCA, but their chronic requirement for fentanyl was not met because they were chronically on a fentanyl patch. So the patient's pain score was not controlled. This happened over on a Friday, and they weren't seen by the pain team up until the Monday, and the patient's pain was not controlled up until Monday when pain team reviewed it. So if a patient is on chronic pain relief, please make sure you put them on their chronic pain relief, or they'll go into withdrawal because they need what they're on chronically, plus they need what they're on acutely as well for their reason for the admission. This is another scenario with a summary care record that was printed. So patient X was admitted to A&E, and their summary care record had all their medication history, and that was printed out and put in patient Y's medication. Patient Y ended up in ITU. Patient X stayed in A&E and went somewhere else. The ITU doctors looked at the medication record and found all these drugs, and they put them and prescribed them all on the patient's drug chart. So if you do see a summary care record, please double check that you've got the correct patient before you prescribe everything, because that patient received all the wrong medications that they shouldn't have received for another patient in A&E. So if you've forgotten everything that I've said, please write in capitals, please use black ink, please don't write IU or units next to a number, write it below it. We have a no blame and shame culture. If you have any mistakes, please document them and please share them so we can learn from your mistakes and we can share them with future prescribers. And that's all. Any questions? Okay, thank you all for your time. Thank you. Bye-bye.